All right, you guys, let's wrap up chapter 20, finally. Let me swig my bang. Okay, so we have, I believe there's 2 topics left to cover in the rest of this PowerPoint, and that's drug resistance and also allergy. I want to mention those. Okay, so we've talked about superbugs, resistant strains of bacteria that are able to, grow and cause infections, even though they're given an antibiotic that theoretically should work against them. And that's what we mean by resistant strains. Okay, why do you guys start growling the minute? They literally are quiet every other time, and then as soon as I start a video, then all of a sudden hell breaks loose. I don't know. Anyway, so the definition of drug resistance is when the microorganism, and I'm mostly going to refer to bacteria, so I'm just going to say bacteria here, begin to tolerate an amount of drug or antibiotic that normally would either inhibit or kill them. So there are 2 main ways that bacteria can have this happen. Either their DNA randomly mutates, because there is a baseline mutation rate that affects all of our cells. And it just happens to produce, perhaps now they can produce an enzyme that can, chew through the drug. And so it's able to deactivate the drug. That's one way. That's called intrinsic, and that means it's happening in the DNA of that particular bacteria. Or, remember, we've talked about those little small circular pieces of DNA called plasmids that bacteria can randomly pass back and forth. Well, perhaps there's one bacteria that's carrying a plasmid that has a resistance gene on it, and then those conjugation pili form, and it just happens to pass that plasmid to other bacteria, and so that they are acquiring the resistance gene from a plasmid from another bacteria. So, a couple of things that can happen here: spontaneous mutations in the bacterial chromosome, okay, that allow it to be resistant, or getting it from a plasmid from another bacteria. And we refer to those as resistance factors, or, getting a plasmid is acquired drug resistance. So this is really what's happening. You have all of these, if this were, let's say in a human, you would have all these different bacteria that are not drug resistant. And so when the drug is taken, you get rid of all of those, right? But then you happen to have these drug resistant mutants that once the drug is not there anymore, they're like, whatever. And so they start replicating, and then their population grows over time. And eventually now you're populated with a drug resistant strain. So one of the things I mentioned earlier was that patient behavior has a lot to do with drug resistance. Now, we're humans, right? And humans, God knows, prime example right here, are not perfect. So, how many of you, when you've been prescribed an antibiotic, immediately rush to the pharmacy, pick up your prescription, start taking it, and then you set a timer so that you precisely take that drug at, every 8 hours or every 12 hours, okay? There's probably a lot of us that don't. Maybe some people do, good for them. Or let's say you're the parent of a small child. Child has been diagnosed with a bacterial infection. They're miserable, they haven't slept. So you get 1 dose of antibiotic in them, you finally get them to sleep, and then you're supposed to wake them up in an hour and give them the next dose. But you're going crazy, you want that kid to just sleep, so you figure, I'll wait a couple hours. That happens, of course that happens. So yeah, if we don't take the antibiotic at specific times, and actually, let me try to diagram what's happening here. Okay, hold on for 1 second. I'm just going to draw a little chart. Okay, so let's say that this is the number of cells, the bad guys, okay, and this is time. Okay, so you want to give a level of a bacteria or of an antibiotic at a bacteriostatic concentration. Okay, so what that means is it's going to prevent further growth, and then hopefully your immune system is going to come in. Okay, and let's say that this is the therapeutic level of the drug that you would need to take to be effective, and you need to take it every 8 hours. Okay, well, let's say we have that example where, God, I just got my kid to sleep. I'm going crazy. I need some sleep. So you don't give it right at the 8-hour mark. What happens then is that the drug dips below its therapeutic level and then won't go up again until you give the drug the next time. Well, in this time period, okay, now you have cells that, they may be weakened by the drug, but they also now have time to become resistant. So it's important to keep giving that drug at a constant time because you want to keep it up at this theoretic level. Theoretic, what am I talking about? Therapeutic level. Jeez Louise. Not caffeinated enough yet. So that's why we're supposed to take our antibiotics at particular intervals. But we are humans and life interferes, and so we don't do that all the time. Okay, so that's one cause. Another cause that I think is really common is when patients feel better, and so they're like, I'm not going to finish taking this antibiotic. Why would I? I feel fine. I'm all better. Most antibiotics are prescribed in a 10-day course, maybe up to a 2-week course. It's really important to finish the entire course, because if you don't, once again, the same thing is going to happen. You're going to kill off most of the susceptible bacteria, but not the ones that you're not going to kill are going to be weakened and then perhaps come back stronger as resistant strains. So even though it seems like overkill, yep, you should finish your entire course of antibiotics. People don't do that also because, maybe their antibiotic is making them sick to their stomach. They don't like, side effects. And that certainly can happen, especially in the gut, because when you give an antibiotic, not only are you going to hopefully kill the bad guy, but you're going to get rid of a lot of normal bacteria. And so your gut flora is going to be knocked out of whack. And it's really common for people to get diarrhea and colitis because of that. So, but, it really is important to finish the entire course of the antibiotic. Okay. Then, of course, we've had overprescription of antibiotics by healthcare providers. Now, do I think this is just laziness or they're dumb? Absolutely not. I think the reason for this is because, once again, you guys are human. You don't have a crystal ball, and we don't have a rapid test that you can do in the office to tell you exactly what is going on. So wouldn't it be wonderful if you had a patient come in, you wanted to determine, is this a viral infection or a bacterial infection? Take a swab, do a rapid test, boom, comes up 100% bacterial, and then you can prescribe accordingly. That would be awesome, but it's not reality. So I think a lot of healthcare providers are like, I think it's viral, but something bacterial could be starting now, some type of secondary infection. So, I want to cover all the bases and make sure my patient gets better. So yeah, I'm going to give you a prescription for antibiotics just to cover everything. And I think that happens. And it's certainly not, there's no ill intentions or malpractice by the healthcare provider. They just want their patient to get better. The other thing to keep in mind, see, this is what I'm dealing with. You guys, trying to teach, okay? Thank you. The other thing to keep in mind is, in microbiology, we've talked about one type of microorganism at a time. So keep in mind, patients can come in with mixed infections. So they can have a bacterial infection and a viral infection. They could have a gram-positive and a gram-negative infection. They could have a fungal infection. So, it's a really complex puzzle, and you guys are the ones that have to figure out, okay, what the heck is going on? Okay, and then of course we've mentioned this, spontaneous mutation. So remember, one of the big keys is that there's no such thing as a drug that is free of side effects. The closest we came was penicillin, because it acted on a compound that our cells don't have and only bacteria has. So yeah, it was perfect. But unfortunately, now we have resistant strains and we have a lot of patients who have allergies to penicillins. So toxicity to organs, when we're talking about antimicrobial drugs, basically anything, liver and kidneys, certainly if it's heavy metal based, the GI tract, your bone marrow, skin, bones, teeth, all over, you can have different side effects. So increasing the concentration of the drug from bacteriostatic concentrations to bactericidal usually increases the side effects. And so, but hey, if you have a MRSA infection and it's in your bloodstream, that can be quickly fatal. So guess what? We're going to hook you up to an IV bag. We're going to give you the strongest dose of vancomycin that we can, and we're going to try to manage those side effects. Either that or it could mean the end of your life. So yeah, certainly, you do what you have to do to, help the patient. Here's an example actually from my own childhood, and I don't think we have anyone in the class even near my age, so you probably have never seen this before. But when I went to grade school, there were kids in my class that all had this brown line across their adult teeth, not their baby teeth, but it would be across their adult teeth. And what this was, it was from little kids being given tetracycline, when their adult teeth were still developing. And actually, it was so common that I don't think, I certainly didn't blink an eye. It was like, oh yeah, you're one of the kids that has the brown stain across your teeth. It was actually really common. Of course, pediatricians didn't know this was happening until they started seeing it in older children, and so they stopped prescribing tetracycline. And this was not something, this was permanent. It was not something that, you can bleach your teeth and it would come out. It would basically be, you have to have veneers, some type of cosmetic dentistry to get rid of it. So that was not something that affected an organ, but it certainly, could affect the person cosmetically, their self-esteem. And it was simply from being given a particular antibiotic during a certain developmental period, and it happened to have that side effect. So that's why tetracycline, stopped being prescribed to younger children. Okay, now let's talk about allergy. So the definition of allergy is a heightened sensitivity. And what it is, I think we all have friends like this that there's the little bit of drama and they just totally blow it out of proportion and they overreact into really what is not, something that's not a big deal. That's what allergy is. So instead of just being like, oh, hey, there's a drug molecule, whatever, for some reason, people who with allergies, their cells freak out and, put out this huge allergic response to a drug. So the drug is acting as an antigen, and an antigen, which we'll discuss in depth in chapters 16 and 17, is something that stimulates the immune system to react. So when you have an allergy to a drug, it can include, a skin rash, in worst case scenarios, respiratory inflammation where the person is having a hard time breathing, rarely, thankfully, anaphylactic shock. But, this is the reason why some people, carry EpiPens, or why, especially on your medical records, you should have listed what drugs you are allergic to. Actually, let me show you an example, and this was from a neighbor of mine. Of course, this is the danger in being friends with me, because anytime you have kind of some weird, rash or something I can use in class, I'm always going to want to take a picture of it. But let me show you this real quick. So this friend of mine she had a UTI, and, she was taking an antibiotic, a sulfa drug to it, and I was sitting in my house, and her young daughter came running across the street and said, my mom just collapsed and fell down the stairs. Okay, so we call the ambulance. So when she went into the hospital, this is a picture of her back, what her back looked like. And then this was the front, okay? So what this is her immune system battling back and producing an immune response to sulfa drugs. And that's also a very common drug allergy. And actually, the reason she had passed out was because her body was putting so much energy into the allergic and inflammatory response against the drug that she lost blood pressure, passed out, and thankfully just rolled down the stairs. She didn't break any bones, there weren't any other injuries, but her losing consciousness was totally due to an allergic response. So yeah, it can be pretty serious. You're not going to see the reaction usually the first time you take the drug. It's the second and third and fourth, and hopefully there will only be a second time, because after that you'll know that you're allergic to it. But that's what allergy is. It's just a super heightened sensitivity to a drug. Okay, so I want to mention the term normal flora. So this I've talked about a little bit before, but your normal flora are bacteria and usually fungal cells like yeast that are in and on you all the time. So normally they're harmless. They can be beneficial, like we talked about E. coli synthesizing vitamin K. And yeah, you're always going to have a small number of pathogens, right? But they're not going to start overgrowing because of this term, which is important, microbial antagonism. So remember, it's very healthy to have all of these different species of microbes kind of fighting for turf, because that prevents pathogens from being able to overgrow. Okay, this is one of the problems we see, especially if we use, for example, a broad spectrum antibiotic. It would be awesome if we could program our antibiotics to say, hey, this infection is being caused by, let's say, Pseudomonas aeruginosa. So I want you to just go in and kill Pseudomonas aeruginosa. That would be awesome, but unfortunately, that's not the way it is. It's going to go in, and if it's a narrow spectrum antibiotic, it's going to kill all gram negatives. So great, Pseudomonas aeruginosa will be killed, but so will the E. coli in your intestine. That's good for you. If it's a broad spectrum antibiotic, then it's going to kill pretty much all of the bacteria, which is going to destroy your normal flora. That is what can lead to what we term opportunistic infections, or the term is actually a super infection, which is a super dramatic term. Okay, so examples of these, and probably, some of you gals have experienced this. So, you go in for a UTI, or you even go in like for a sinus infection, you're given an antibiotic, and then boom, you end up with a yeast infection. What is happening is that the antibiotic, and it's getting rid of the bad guy, but it's also destroying the normal bacteria located in the vaginal environment. And now yeast cells that are normally present in that environment can start to overgrow. Remember, Candida albicans is yeast, and yeast is fungi. So an antibiotic is not going to touch it. Okay, so that's why that happens. That's an example of an opportunistic infection or a super infection. The other thing that can happen is if you're on tetracycline, clindamycin, broad spectrum antibiotics, it's going to wipe out pretty much everything in your gut. And now you could potentially have a bad guy overgrow in your gut, and now you get colitis, you end up with diarrhea, stomach cramping. That is another example. So, unfortunately, we can't program our antibiotics to just go in and kill one particular species. There's going to be a lot of collateral damage along with it. But that's what a super infection or an opportunistic infection is. Okay. Anyway, basically showing you what happens. Take antibiotic. Remember, once you take antibiotics, it's going everywhere in the body. So you may have an infection in your throat, but guess what? Now it's everywhere, and it's going to kill bacteria in other environments as well. Right here, it's shown in the gut, and now a bad guy can potentially overgrow. So what happens if the treatment fails? Okay, so there's a couple of reasons that can happen. One, perhaps there was a drug that was not able to diffuse into the particular body compartment that it needed to. You know, I talked about how there's very few drugs that can cross the blood-brain barrier. Even something as simple of your sinuses. So if you get a sinus infection, sinuses are actually a really hard place to get antibiotics to reach. They're not very vascularized. So sometimes that's the problem. Also, there can be a few resistant cells that just happen to be there, you know, by genetic mutation, and now they're going to overgrow. Here's one that I really want you guys to think about, because your patients, and especially the older, and you know, if they have other health conditions, they're going to come in and they're probably going to have mixed infections. And so they may have multiple pathogens making them sick, and maybe some are resistant to that particular drug. And then you're going to see the patient coming back in a couple of weeks and saying, well, I'm still sick. You know, you didn't fix me. And, you know, true. Once again, it's because the best you can do is make a hypothesis based on the signs and the symptoms and perhaps any lab results that you have for that patient. But, you know, you're not superhuman. You don't have X-ray vision. You know, so just prepare yourself that this is going to happen. But of course, patients get mad because, you know, you're supposed to make them better and you're supposed to do it the first time. And it, you know, but, you know, you're not superhuman. Hey, look at that. Yay. Okay, we're all done with chapter 20. I'm going to get this uploading. Thank you.